Hello, my name is Wajaha, and today we're going to cover pyloric stenosis. So get your pen and paper ready and let's get started. So I just want to start off with some basic anatomy to begin with. At the top here, we've got the esophagus, which forms the gastroesophageal junction. The stomach's got a number of different anatomical parts: the cardia, the fundus, the body, and then the pylorus, which consists of the antrum, canal, and sphincter. And this joins the duodenum, which forms part of the small intestine. Now, these are all surrounded by smooth muscle, which contracts and relaxes to help aid with gastric emptying. Now, as you can see from the diagram I've drawn, pyloric stenosis is a narrowing of the opening between the pylorus and the duodenum, and is often caused by excessive hypertrophy of the smooth muscle surrounding the pylorus. Now, this narrowing is significant because what it means is that the gastric contents can't be emptied into the small bowel. Now, it's a condition that predominantly affects younger children, and it's much more common in males, especially firstborn. Now, in some cases, there can be a positive family history, and that's because certain genes are involved. One of them is called the infant hypertrophic pyloric stenosis 1 gene. As well as that, infants exposed to things like erythromycin are at an increased risk for developing hypertrophic pyloric stenosis, especially when the drug is taken around the first 2 weeks of life. So moving on to the presentation, the most characteristic is vomiting. Now, this isn't just normal vomiting, this is full-blown projectile vomiting that usually occurs after eating. Now, the vomiting also contains no bile, as bile is usually secreted in the small intestine, so just watch out for that on exam questions. Now, because of this, these children are often super dehydrated. So you may see signs of dehydration like a sunken face, poor skin turgor, tiredness, and tachycardia. That's just something to be aware of. And finally, they may also have an olive-shaped mass felt on examination in the abdomen. So the three things I want you to remember from this: projectile vomiting, dehydration, and an abdominal olive-shaped mass. Now, to investigate this, ultrasound can be used. It's easy, it's cheap, and it shows a muscle thickness. So that's the gold standard. We may also do a test feed, in which case we may see vomiting straight after. Now, one thing that's really important to know about is that as a result of the excessive vomiting, electrolytes are often imbalanced. Now, the loss of acid from vomiting results in a low chloride level, and the kidneys, in response to low protons, let go of potassium, resulting in hypokalemia. If you're vomiting out protons as well, you're often left in an alkalotic state, so we check blood gases too. Now, to manage these patients, we first of all make them kneel by mouth, just to stop them from vomiting, and then we pass a nasogastric or nasojejunal tube down. We can help to rehydrate them with fluids and replace electrolytes like potassium. Now, it's only once everything is stable and blood gases are stable that we can do surgery, and one of the procedures is called a pyloromyotomy. Now, to help you guys remember this all, here's my mnemonic for today. Olives, really simple, really easy, so let me break it down to you. O for olive-shaped mass. Then we've got loss of water, as these patients are dehydrated. Infants, which helps us remember the demographics. Vomiting, electrolyte disturbances, and surgery. Remember olives, and if anyone ever mentions pyloric stenosis, you know everything that you need to know. So lastly, just a couple of questions. A 1-month-old boy is brought to the emergency department by his mother, who states that he has been having what she describes as projectile vomiting for the past several days. She states that he vomits every time she feeds him, and the situation seems to be getting worse. Although he does not seem to be in pain, she describes the vomiters as non-bilious, and he has had normal stools with no blood in them. On examination, the infant appears to be mildly dehydrated, his abdomen is soft, and there is a palpable olive-sized, firm, movable mass in the right upper quadrant. Which of the following is the most likely diagnosis? So quite a straightforward question. We've got an infant with the triad of symptoms I mentioned: the projectile vomiting, dehydration, and an olive-shaped mass. It can only be one thing, and that's pyloric stenosis. Lastly, A 4-month-old baby is brought to the ED with vomiting for the past 3 days. His mother describes the vomiting as projectile that occurs after every feed and is not settling. On examination, the baby appears well. Heart rate 140, breast rate 36, blood pressure 90/60, cap refill 3 seconds. Mucous membranes are slightly dry. He's afebrile. The pediatric registrar comes down to review the baby and decides to admit him for further investigations. Which of the following investigations would be the most useful to determine the diagnosis? So as I mentioned, we want a quick, easy test, one that shows the thickness of the pylorus. What do we go for? Ultrasound is a very good test that we do and is the gold standard. So that's the answer. That's all I wanted to cover today. Thank you very much for listening. Please like, comment and subscribe, and I'll be back with another video soon.